That my task is to speak about minor bleeding while under DOAC, how to manage. As an introduction, since the approval of direct oral anticoagulant DOAC in 2013-2015, it depends on the countries, the use of DOAC has increased rapidly in the world. DOAC are used in, like you know, in stroke prevention, for in atrial fibrillation, in treatment of venous thromboembolism, and in medical and surgical thromboprophylaxis. Warfarin was used since 60 years, but now it's useless because of the inter-individual variability in dose requirement, narrow therapeutic index, low intherapeutic range, and food and drug interaction. We know that bleeding is a very important issue with anticoagulant therapy. 60,000 deaths annually in the United States, 1.9 million deaths annually worldwide, and people who survive from an initial bleeding insults have a high long-term mortality and a poor functional outcome. So it's a very important risk factor in the future. 6 million patients are treated now with anticoagulant in US. What is the definition of minor bleeding? Minor bleeding is everything that is not major bleeding. If we eliminate major bleeding, it's minor bleeding. Minor bleeding is mucous membrane bleeding from gingiva, from gastrointestinal tract, from genitourinary system, epistaxis from conjunctiva. So it's minor bleeding as any sign or symptom of hemorrhage and clinically relevant bleeding. Major bleeding is a bleeding at a critical site. Critical site, it means intracardiac, intracranial hemorrhage, pericardial tamponade, airway hemorrhage, or extremity bleed hemorrhage. It's a hemorrhage with hemodynamic instability, or hemorrhage that make hemoglobin drop more than 2 grams per deciliter, or that need administration of more than 2 red blood cells units. So major bleeding and minor bleeding are almost frequent with DOAC. It represents minor bleeding represents an average of 10%, and major bleeding an average of 2%, so it's a little bit high. So we have to keep in mind that there are drugs that can provoke this complication, and the risk is high with low doses. This is a little bit paradoxical, but low doses are prescribed to frail patients. That's why the risk is more important with low doses. And what are the risks of bleeding? Age. Elderly people bleed more than young people. Heart failure, renal failure. So when there is a kidney failure, the risk of bleeding is more important. Peripheral artery disease, CHATTAOUI score. The high is the CHATTAOUI score, the high is the risk of bleeding. Hasbler score, of course, and atria score. So speaking about score, there are three important scores that we use in our daily practice to evaluate the risk of bleeding: Hasbler score, atria score, hemorrhage score. The common factor is age, bleeding in the history of the patient, and renal failure. The most sensitive in the study, the most sensitive score is definitely Hasbler score. It's a score that permits to evaluate closely the risk of bleeding, major or minor bleeding. We know from the initial studies and from the real-life studies that DOAC can cause bleeding, and they cause bleeding less than warfarin. That's what we know. all of them, so for all bleeding, bleeding with hospitalization, gastrointestinal bleeding, major bleeding, they are better than warfarin. And if we go deeply and we try to see with individual DOAC, all do the same. They are all better than warfarin in terms of risk of bleeding and even in terms of preventing death. The relationship of the risk of bleeding and renal failure is very important to know, especially in end-stage kidney diseases. And as you see in this slide, the risk is equivalent when the renal function is normal. But the risk is more important with warfarin when the renal function is decreased. And when, as you see in the slide, when you go across the glomerular filtration rate, we see that in the end-stage patient, in the end-stage patient, DOAC do better than warfarin, and it's significantly different. So that's why we are switching to DOAC in patients with severe renal failure. So what should we do? How to manage minor bleeding? We have to check if the patient have supratherapeutic doses. We have to see if the patient has if an underlying risk of bleeding has changed with time, a deterioration of renal function or hepatic function, or introduction of a new medicine. We have to check if the patient have a severe anemia requiring transfusion, and if the patient does have relevant comorbidity like frailty or an active medical issue like myocardial infarction. And we have to see what is the origin of the bleeding and if we can control the bleeding. So we have two situations. We speak about minor bleeding. So the diagram on the right. So if we can control the bleeding, we have to think about continuing the prescription. But if we cannot control the bleeding, or we don't know from where the bleeding is, we have to delay. And when we keep controlling the bleeding, we have to decide, and we have to rethink about the indication of the DOAC before restarting them. If the patient needs the anticoagulation, and we have to speak with the patient to have his approval, and perhaps we can suggest delaying the restart of the anticoagulation. Is it important to do the laboratory measurement? We know that for minor bleeding it's not mandatory, but we have to know that we can do assay suitable for quantification of DOAC, and we can do assay an assessment for qualitative qualitative measure. It means that we have or we don't have, but we cannot quantify. It's important, especially in patients that have renal failure. We have to think about half-life clearance of the DOAC, and to know that half-life is more important with dabigatran than with apixaban and rivaroxaban. Especially, we have to focus on the withholding DOAC, because half-life is something, withholding is another thing. Withholding is an average of twice or 3 times half-life. It's about 3 days when there is a renal failure with dabigatran, and 2 days when there is an end-stage renal failure with apixaban and rivaroxaban. So we have to think about all these parameters to know how to manage our patients. The problem is, and this is a very interesting study in UK. It's a real-world data reported to the National Reporting and Learning System. So most of the problem of bleeding are in relation with error, as you see on the table on the left. Slips, lapses, mistakes, lack of knowledge represent 90% of the damage and the harm caused by DOAC. So we have to explain to the patient, we have to make him adhere to the program and to his treatment, and we have to be very accurate. Prescription of DOAC in United Kingdom is increasing, and now the prescription of DOAC represents more than 90% of the prescription of anticoagulant. In the meantime, the cost of anticoagulant treatment rised a lot as well, because general practitioners think and feel that the prescription is easy now and they can prescribe easily and there is no harm. They have to think about the problem of the anticoagulant therapy in terms of bleeding, because bleeding can cause death. And and we have to keep in mind that in every 10% increase in prescription of DOAC, we have 0.9% increase in admission for bleeding and clotting complications. So DOAC are better than warfarin, but they are still drugs that can provoke bleeding and severe bleeding, and minor that can become major bleeding. So in summary, in conclusion, the trend of use of DOAC is increasing. DOAC as anticoagulant therapy still causes bleeding. We have to keep in mind that they are drugs that can cause bleeding. Regulation, specific guidelines, and follow-up is essential, especially in frail patients. Minor bleeding can lead to major bleeding. There is no minor bleeding because every minor bleeding can become major bleeding. Bleeding is a strong risk factor of recurrence and carries bad prognosis. If you have a patient that have a history of bleeding, it's a patient at risk. And bleeding should make physicians think about the indication. When the patient bleeds, we have to rethink about the necessity to continue the treatment. Thank you very much.